It's off exit 10, presented by Capital District Sport and Fitness.
Yeah, he's a good kid. Great kid.
Definitely. Are you from around here?
Yeah, I'm a Gildan guy. Kindergarten all the way through.
Yeah, man. And what led you into this realm, into sports and orthopedics? And
in case you were wondering, that clap meant that we're
rolling.
We're rolling. There we go. Yeah. So I'm a hometown guy. Kindergarten all the way through. Grew up here. My dad was a physics professor at U Albany for 40 years. He's passed on now. And I was always interested in sports. I played all the way through. I played football and lacrosse all the way through high school. Then I played lacrosse in college. But I, had some injury, I remember, to my knee when I was young. And my dad was more of a tennis guy. So he was like, maybe your football career should be over. I was like, yeah, that's not happening. So my first exposure was to orthopedics at that time. I think this was during Pop Warner. So I always, for whatever reason, said I want to be a doctor. And it was funny because my second grade teacher was friends with my parents, and she pulled out something that I wrote, I want to be a neurosurgeon. So then I joked, and this was in second grade, that I got smarter and decided to be an orthopedic surgeon years later. So that kind of was always in my mind. I played sports all the way through. I saw, what the impact that doctors could make in the orthopedic field, where someone, comes off the field with an injury, we rehab them, we do surgery, and we get them better. So immediate gratification. In orthopedics, I treat all different ages, from the, older person that's fallen and broken their hip, where, we're fixing that, versus the high-level athlete or the kid who's got some type of injury. And most things are non-surgical, but obviously a lot of things are surgical. Mm-hmm. So it's the variety is awesome. So it was something I always wanted to do, and I wouldn't have done anything different. I've been lucky all the way through that how things worked out for me.
Yeah, when I'm talking to kids in here with like college coming up and trying to figure out what they wanted to study and whatnot, I'm like, some kids know.
Yeah.
At 8 years old what they want to be, and like some kids you don't figure it out till you're in college.
Right.
And like
and
that's okay.
There's nothing wrong with that.
And it's funny that you bring that up because there's definitely kids that I've met that are like, yep, I know where you're gonna be. Like there's a kid off the top of my head, we know he's gonna be a pilot, and he's already it's gonna happen.
Yeah.
So.
Yeah, what I tell people is, you remember, whatever you're going to do this, and be it even just in medical field, you're going to do this for 40 years of your life. Mm-hmm. So if you have the ability to do something that you love and that you get something back from it, it's not like work. Obviously I work hard. I do a lot of different things. I got get pulled in different directions, but I wouldn't have done anything differently. I love what I do, and every day, it's a privilege to take care of patients and help people get better.
It's the exact words my dad would say growing up. Like, hey, you're gonna work most of your life, so find something that you actually enjoy doing.
Yeah.
And that way, or if you don't, find something that pays you enough so you can go do things you enjoy.
Yeah.
Exactly.
Yeah.
Or both.
100%.
Or both. Ideally both.
Yeah. If you can do both, it works out well.
Yeah. You were a lacrosse guy though.
Yeah. Yeah, so like I said, I grew up here, kindergarten all the way through. I was a Gildan guy. Then I went off to college at University of Rochester, where I played lacrosse. And then ultimately went to med school in Virginia. And then, orthopedics, you got to do about 5 years of training. So then I came back home and did my training in Albany. So the funny story I'll say is, what happens is the way orthopedic residency or residency in general works, it's like the NFL draft. So there's a thing called the match day. So all people that are graduating from med school,
you got to rank your schools.
You got to rank your schools,
and they rank you.
Yeah, so it's kind of a thing. You're ranking your schools, they're ranking you. Then you go for interviews, and then on the same day, throughout the country. It's called Match Day, and in my case, it happened to coincide with St. Patrick's Day. And my wife's family, she's Irish, so it was kind of, we were thinking this could be good luck. That ultimately on that day, you open up this envelope and you find out where you're going, and you don't want to get the phone call on Monday. That's unmatched day. So if you didn't match somewhere, you're getting a call earlier saying, "Hey, you got to start the scrambling process." And so if you get through Monday, I think it was Monday and Wednesday. Monday, you're at least going somewhere. then Wednesday you open up this thing and then you find out where you're going. So, we had a big party that day on St. Patrick's Day for sure. When I found out I was coming home, my wife's from this area. She's a Guilderland person too. So it was a good day.
That's a good day to celebrate too. So
absolutely.
Yeah. But lacrosse, we didn't grow up around it. We went to a small school in Chatham. They didn't have it. I didn't know what lacrosse was until I got to college.
Yeah.
And then didn't even watch a game.
Yeah.
And then we have so many kids in here that play.
Oh, it's crazy.
I feel like it's a growing sport, or maybe it's always been there. I just haven't been in that world.
For sure. So when I was in high school, football was our main focus. But my coach, who subsequently passed on, but he was a great guy. He was a art teacher. His name, funnily, was named Art Wah. So his wife was my English teacher, and he was our football and lacrosse coach. So he was a good lacrosse player as a goalie, and he kind of recruited all the football athletes to say, you got to start playing lacrosse, or you'd like lacrosse. They got sticks, and we were no good. We'd be hitting people, and there's more good. The stick skills that they have now are unbelievable. And I've since I started practice, I've been involved with UAlbany athletics. So, and I always have been taking care of lacrosse since I started practice. So to see the revolution of lacrosse, the Thompson twins, those guys, Thompson brothers, it's really unbelievable. It's such a fast game, and I love watching lacrosse.
Yeah.
So
my very first lacrosse game I ever watched was two girls in here. One went to UVM, one went to UAlbany, and I was like, this is pretty sweet.
Yeah.
This is a pretty cool sport to watch, and it's I like how it incorporates a lot of different other sports within it as well, which is kind of cool and whatnot. So
yeah.
What's been the biggest evolution in the youth sports world that you've seen over the years from working in orthopedics and from having your own? You have how many kids?
I have 2 kids.
Just having your own kids go through that.
Yeah. So, definitely things have evolved, and that there's definitely more competition and being more sports specific, that at some point you got to make some decisions, which is hard, because I love the situation where, you rolled into basketball season, then you went into lacrosse, then you played this and that, and you're doing other things. But unfortunately, from a competitive standpoint, it definitely has become more sports specific.
Do you feel like those years are behind us, where a kid can roll in to hoop season, to baseball, to football, and by just doing their school and just doing town and rec?
Right. I think to some degree, yes, that you probably got to pick 2 sports. 2 I think is still reasonable, but it's probably rare to now be able to do the 4-sport athlete that we used to have in the past. Now, of course, a byproduct, these players are way better than we were. They're faster, stronger. In the off season, they're doing other training to be ready for the time, so it's I guess there's a trade-off to it.
I think there is a trade-off. We see it, and I'm sure you see it too, because to us, what forces that, bigger schools put that pressure down sooner, because a Shen, a Guild, they got the same roster sizes as a Stillwater, as a Mechanicville, with this much bigger of a student body. So it's just the pressure to get into that system earlier, I think people feel, which forces them.
Right. I mean, unfortunately, what happens, I think, because of that, some people that maybe don't have those skills may be out of those sports earlier. So that's where there still is the importance of still hopefully having these rec programs where you can still go play that sport. Maybe you're not going to be making a high school team, because you know how competitive it is to make these high school teams in these big schools is it's difficult.
You also see more, especially at some of the bigger schools, kids care more about their club or travel team than they do about their school team. And there's just that whole dynamic too. And I was talking to a girl, she's in 8th grade, and she plays soccer and softball. She's still going to play soccer, but she's only going to do school soccer, not club, because she wants to focus more on softball. Right. And I even said to her, I was like, doing club soccer and club softball now at the same, is I feel like almost impossible at a certain age.
You're right.
Because soccer is so crazy, and softball also.
Because of an overlap of just
overlap of practices, seasons, and both things are playing year round with their club teams, their travel teams, not their school teams. So it was cool to hear that she still was going to play soccer though, and still play the school soccer and do that, and then focus more on softball for some of her other more serious things.
Yeah, absolutely. I mean, the problem is also the travel. Travel expense. I remember days when we, well, your colleague here, Matt Pierce, I've known since he was a little kid, and he played many sports with my son. And I remember there was times where, we'd be going from school basketball, then hopping in the car, changing for the CYO basketball, then running off to this hitting in the morning for baseball. I mean, it was like we had another close family. The kids are the same age, so we used to divide and conquer, and we'd be, okay, you're taking these guys here, you're taking the girls to swimming, we got this. So it was fun times, but it was pretty hectic for sure.
Yeah, that's true. Yeah, it's just like time-wise and financially. And
Yeah.
But okay, you have the pressures of the high school pushing kids to get into funnels earlier, I feel like.
Right.
But then, yeah, once you put yourself into one bucket more, let's just say it's baseball.
Sure.
Yeah, you have to start to weigh the pros and cons of like just the benefits for your body, becoming more well-rounded, going through more movement patterns, bigger variety of things.
Absolutely.
For your brain and for your body versus like, okay, now at a younger age, I'm force specializing. I'm just doing this one rotational skill a lot more.
Right.
How do we weigh that in terms of like what's an ideal age range where your body, your bones, your tendons, your ligaments, your muscular system can handle more repetitive movements, more load that is the same type of load over time versus when you're younger, you may not tolerate it better, or do you feel like you tolerate it better when you are younger?
Yeah, I think, like talk about weight training and certain things like that, that probably the science now is telling us that maybe there's not as much worry of these growth plate injuries. It hasn't been bared out in the science that you're going to get a growth plate injury if you're doing the X, Y, or Z. But I think the critical thing is having good mechanics, having adult supervision by somebody who knows what they're doing. So you were doing those body mechanics, and you start off with basic stuff, maybe body weight or stretching, combination things. But as your body adapts and you start getting more able to do those things, maybe your strength and flexibility are pretty good. If you have the right supervision, then it is safe to start doing a little bit more complex body maneuvers type thing.
When you're looking at kids pre-puberty, that's what you're seeing, mostly growth plate type injuries.
Not necessarily. Is that the issue is obviously that's what we worry about. If any of us have an injury, our growth plates are closed,
Right.
So we're not worried about growth plate injuries. But in kids, obviously growth plates are still open, so that's the weak part of the bone. So say if someone has an injury when they have an open growth plate, we worry about maybe a non-displaced fracture of that growth plate, which you don't want to kind of push through it. Next thing it displaces. Next thing you're putting screws or pins in something that didn't need to if we just shut it down and heal. So it just makes it a little bit more complex having the growth plates open.
And that's going to come from both trauma and overuse?
Can be, yeah, both things.
And then as we get into our older ages, and let's say we are specializing, and let's stay on the baseball kind of path, what are the most common injuries that you are seeing?
You're talking about like
Let's
high
talk about
school or college.
Let's talk high school, college, baseball athletes.
Yeah, a few years. I used to do this for years, but I haven't done it for years. I think before COVID, I used to always give a lecture to the area coaches, trainers, athletes about throwing injuries in athletes, in that there's a huge interaction between the shoulder and elbow. So, if we're ever looking at an elbow problem, any thrower comes in and tells me their elbow hurts, I'm looking at their shoulder first, in that because the biomechanics of the throwing shoulder are so complex that if the things are a little out of whack in the shoulder, and a lot of times even a trained professional, good pitching coach might not start seeing these subtle things where people are changing their arm angle, they've got a little decreased internal rotation, they start having different release points, they start putting increased stress on the elbow. So it's critical for a thrower, you got to assess both and treat both at the same time. And I will say if you get to it early, and in some ways sometimes I like it when someone has some minor type stuff when they're in adolescence as a thrower, because it's like you're going to get educated with the right people working on the right things, and you and your family are going to learn how to do the exercises and activities to maybe keep you out of trouble. So it's a little hassle right now. You're going to miss a little time, but in the long run, it's going to probably pay a dividend for you.
What we see a lot is, and we've gotten better at this over the years, it's like a kid will present, let's say when they're 13, with like some forearm pain and discomfort.
Right.
And then they don't shut down, and they may, it's just like a pronator, it's just let's go to the shoulder. But that UCL has started to fray a little bit.
Right.
And I think it's so important to catch it early on.
Yeah.
Because then we see the story of, well, my elbow hurt when I was 13, then it got a little better, then it hurt again 2 years later, then the next year, and it's just been that UCL just over time.
Absolutely.
Just fraying and fraying until it finally.
Yeah, it goes. So that's kind of the concept is that, you see something, say something. So that's why when I was involved earlier with, these guys helping out coach, my guy, one of my friends is a good baseball mind, and he coached these kids forever. I was there as the, help from a medical standpoint and do this and that. But I always was big on, if you start having some problem, these guys are not complainers. They're not going to always tell you it's hurting them. But if something's a problem, there's no advantage of playing through it. Let us know what's going on and try to be as safe as possible for your own longevity. So that was kind of always our thought on things. And the, something, if this gets caught early, my forearm's hurting me, I got a little something, you shut down for a period of time, get the right treatment, which is normally just going to be physical therapy, stretching the back of the shoulder, making sure the mechanics are sound. And for a thrower, there's a huge association between core strength, the strength on the contralateral hip. You guys probably deal with it all the time.
Throwing's hard because it's so multifactorial.
For sure. The thing that I talk about, the throwing motion, is when I used to give that lecture, I'd show the whole, diagrams of how stressful and how much, torque is put on that elbow and shoulder, elbow for sure, during the throwing motion. So the mechanics are really critical. So I think the issue is, everybody tries to educate everybody. So the more the coaches understand what's going on, the parents are engaged, how to keep my kid healthy, the player themselves, everybody's got to be on the same page, knowing their body and when they're starting to have a problem, and that I think that really helps things.
Yeah, because you have the mechanic, and you said you're looking for a deficit in IR is a red flag for you.
Absolutely.
What about total motion? Are you looking at total motion between sides?
Yeah, well, if you think of the thing is, on your dominant side, you're always going to have, in a thrower, you're going to have some pretty good external rotation. But if you think of the total arc of motion, so I say if you think of shoulder range of motion, it's 360 degrees. And when the most throwers on their throwing side are going to have more external rotation than they have on their uninvolved side. When that gets a little out of whack, where you get a little too lax in external rotation and a little too tight in internal rotation, that's when the body's a machine. So it senses something's wrong, and that's when you start changing your mechanics, and that's where potentially there's risk of injury.
Yeah, because the biggest we see too is when you have that increased layback because you're a thrower, because you've been throwing so much more.
Right.
And yes, you then in sequence lose some of that IR, but having that big range of layback and you can't control those end ranges is where we see a lot of issues in here.
And then the body tries to protect you. Next thing you're getting pain around the back of that, scapula or shoulder blade. And, so that's where, doing foundational exercise, core strengthening, making sure everything's as good as possible, and then keeping up with that stuff is critical, for things. And, especially baseball players, especially in the Northeast, it's pretty cold when you go off. We're starting our season, you're freezing cold. It's, going down to Florida, wherever it is, it's still cold. That I'll say make sure you're warming up, do your stretching, keep things going before, and then they do pretty progressive stuff, no one wants anybody to get hurt, so you're not going down there and throwing 10 innings when you first start out in March.
At least we hope not.
Yeah, we hope not. Yeah,
yeah, we hope not. But you have to also be looking at tissues around the elbow as well, correct?
Absolutely, sure. So, the shoulder's kind of the foundation. But like I said, if anybody comes in with their elbow problem, I'm always looking at the shoulder first. But obviously the elbow is why they're there, so we got to start that too.
The strength and conditioning world too, Dan and I have talked about this, is like for years, that's been the mindset, which is, has a lot of truth. If you have any type of dysfunction at the shoulder, you're going to go down the chain and it's going to impact the elbow. So everybody has hammered at their J-bands, external rotations, working on the scapula, which is great. And everybody's shoulder mechanics have cleaned up a lot and shoulders have been strong. Right. But then we've still seen an increase in prevalence of UCL injuries.
Right. Yeah.
So I think going to the elbow and being like, we still can't neglect these tissues at the elbow that are supporting this UCL as well. You agree?
Absolutely. Yeah. Unfortunately, there's not that much to do at the elbow per se in that way.
Yeah. Give me the biggest muscle groups that are protecting the UCL around the elbow.
Yeah. You get the flexor pronator mass that's there, and then the thing with the elbow is that. One thing I think you alluded to before I was going to mention, I didn't say, is that when you have the youth player, in addition to the ulnar collateral ligament, you do worry about the growth plate in that situation. So unfortunately, probably every year I got some player that either from repetitive throwing, they injure that growth plate, or they might have a fall. That's a little different thing where they can pull the growth plate off, and then we got to do something for that.
Would that be a little league elbow, what people call it?
The repetitive one would be more the little league elbow. But I've had players that were, I can't remember, like wrestlers or something like that, where they've had a traumatic injury, had a quick contraction, pulled off what's called the medial epicondyle, meaning that bone that attaches, pull the growth plate off. Those ones, if it's displaced a certain amount, will open it up, put it back in, put a screw in there to let it heal.
Yeah, because I think we had the flexor pronator group, but we go out in here too. Dan, and you can chime in if I missed something. Yeah, flexor pronator group, just training pronation and supination.
Absolutely.
More isolated. The flexor carpial narrows, just going through like ulnar deviations more.
Sure.
I'd say that's kind of what we hit, Dan. And
Yeah, gripping, making sure we're doing it.
we'll give Dan the mic.
Oh, yeah.
Yeah.
Yeah, just making, we're always training all those things like through gripping, hanging, just supported pronation, supination. And Mike already, I was going to ask, what your take is on why we see, when we were kids, it was always rotator cuff, rotator cuff, rotator cuff.
Right.
And I don't think I knew a kid who had Tommy John until I got to college. Maybe there was one,
Right.
Two tops.
I can name one I knew of growing up.
I can't name any, so
Yeah.
Yeah, and so my question was going to be in your experience and what you're seeing, why are we getting all these we see more of the UCL injuries, or we hear more about the UCL injuries than the rotator cuff injuries now? I mean, my thought process is that we've gotten so trained as baseball players to train those the muscles of the rotator cuff and the shoulder blade, low traps, or all that stuff that's
Right.
going working with that shoulder blade and the movement shoulder, that maybe there is some neglect in the muscles of the forearm, the bicep, everything that's protecting the elbow past the shoulder.
Sure. Yeah, that's a great point. So I think probably, the knowledge of the shoulder and keeping things out of trouble has evolved over time, and it's pretty straightforward, and people can do those things, keep the motion good, keep the thing as strong as possible. Elbow, there's not as much to do down there.
Right.
And to answer your question, now, as you guys may or may not know, but I thankfully had the privilege and honor to train with Dr. Frank Jobe,
Yes.
who developed the Tommy John procedure, did it on Tommy John, and I'll tell you a funny story about that one in a second.
that's pretty cool.
Is that there's been evolution over time, and I think part of the thing is part of what we alluded to before, that people are getting more sports specific. You're playing baseball 9 months out of the year. You're putting more stress on those things, number one. Number two, maybe as you're growing, we have some mismatch in your mobility, so then that can put some stress on the shoulder and the elbow. Number three, people are bigger, stronger, faster. They're just causing more force across things, So it's probably multifactorial. But with Dr. Job's, he's now passed on, but he was a true gentleman and a great man, and kind of a pioneer, obviously.
This was in California?
This is California. So I trained in Los Angeles at a place called the Curlin Jobe Clinic. So a couple funny stories. So he came out of the military and was a family practice doctor. And the main doctor in that place was Dr. Curlin, who was the one who had set up all the stuff with the Lakers and Dodgers, and I can't remember all the teams that they had when he first started, but he had some health issues and couldn't operate anymore. So he met Dr. Jobe when he was young, coming out of family practice residency, and said, "Hey, I'm going to make you famous. You're going to be my hands." So their collaboration started this Curlin Jobe Clinic, and Dr. Jobe was just, very, kind of really humble person and just very smart and really was in tune with shoulder and elbow, and certainly is a pioneer in baseball medicine. And so fast forward to whatever it was in the 70s, where Tommy John tears his elbow, turns his thing, and he can't throw anymore. He's icing it, hitting him with medicines and this and that. And he tells Dr. Jobe, "Well, you got to come up with something." He's like, "There's nothing we can do. Once you tear this thing on here, we can't, your kind of career's over." And he said, "Well, I'll be the guinea pig." I'm paraphrasing. In that if you come up with something, I'll do it. So Dr. Jobe thought about it. He's like, "I don't think we can do anything." He's drawn pictures on napkins, and he says, "Well, there's a tendon we use that, that's not really necessary, that we use in hand surgery, called the palmaris." And he said, "We could take this, maybe we can reroute this around. Let me think about it." And so Tommy John said, "Well, I'm up for it." So They ultimately do the surgery, and his original way we did it, how we did it when I was there in L.A., is we drill tunnel. You still do it in that fashion, but drill tunnels and put this tissue in there to make the new ligament. And at that time, he did the surgery, and Tommy John had bad ulnar nerve symptoms after. So he had to go and do a second surgery, moved it around, and he joked around if that didn't work out well, that he was fine after that, then, this wouldn't have worked out how it did. And ultimately, Tommy John, after his recovery, threw more after that surgery than he did before. So then there's evolution to this whole process. But, it was a, true pleasure training with him, and he was really a great man.
Because it used the palmaris longus, but not everybody has that. Is that
exactly? Yeah, a certain percentage of people don't, and I would say the evolution has been more now using the hamstring tendon, because we take hamstring tendons often when we're doing ACL reconstruction, and that's still used for ACL. But you just have to take one of those tendons, and you can make your new ulnar collateral ligament out of that.
Are you doing any internal bracing now?
Yes. Yeah.
Talk to me about how your experience with that, because we've had a number of athletes in the past 5 years come through with that and have seen good success.
Yeah, so the internal brace is kind of, I'd say, pretty revolutionary thing that's pretty simple. So essentially, and it's used in ankle, it's used in ACL, we use internal brace, we use an elbow. And what it is a suture, and I'll tell you specifically about the elbow in a second. That's to do a little different with it. But the idea is it's a suture material. It's a tape, they call it. And you fix it in some fashion. The idea being that it supports whatever ligament that, in a second we'll talk about ulnar collateral, while that ligament's healing. So you don't want to make it too tight so it constrains it, so that ligament's not seeing some force, but it we think takes a little of the stress off and enhances protects the ligament while it's healing. So that's what it's used for. So internal brace, basically, it's a suture material. You drill a hole in some way, fix it on both sides, usually with a thing called a suture anchor that's made out of plastic or a bioabsorbable device. In the elbow, when you're using it, you can use it for repairs. You can use it for an adjunctive thing for protection. Usually the thing we'll use with that is dipped in collagen. So it's collagen coated, so it has some biology to it that maybe that helps with some of the thought is it helps with some healing.
And when did they start doing this with the UCL, using the internal brace?
It's probably been used to some degree with repairs, so the way the ligament works, if you have what we call proximal or up closer to the, on the upper end, that one's got a better blood supply, so you can do a repair where you save the native ligament, put this internal brace to help with some of the healing and protect that, and that might cut down some of the recovery. Then you've heard of probably this using it as an adjunct where you're doing repair of the ligament, keeping the native ligament, repairing that, putting this brace, internal brace, to protect it, and then also doing the reconstruction with the hamstring.
That's what the TJ3 is, or this new one.
Yes. So it's kind of like a triple crown type thing. And what used to be is when you would do the surgery anyway, you got to go in there, you're looking at the ligament, you didn't do anything with it, or you couldn't do anything with it. So you left it there. I mean, the ligament that's torn, it's not like it's all disappeared from the body. It's just torn off, at the one side or other. And you would do the reconstruction, and then you would sew in your new graft, which would be the palmaris or hamstring or what have you, into the native ligament to give it some support. So now this is just doing a little bit more that maybe if we're getting to it, we're enhancing that, and the tissue's already there, so why not?
Right? Yeah, and from our sample size of seeing guys, and Dan works with our Tommy John clients, who can probably speak more, but yeah, a little bit faster recoveries, just less pain and discomfort during the rehab process. Dan, it moves up the timelines with things.
Oh, yeah. Yeah, we've had, I don't know how many Tommy John guys who have had the surgery or a version of Tommy John over the years. But since we've seen guys doing the
reconstruction,
the return to activity and then subsequently the return to play time is noticeably faster.
Right.
Quick question. Well, at this point in time, is TJ3 like the gold standard of repairs, or is there specific scenarios where you wouldn't go to that extreme for the surgery, or kind of what's the general kind of decision-making process like when you're trying to decide if you need surgery or if you're a candidate for one of those surgeries?
I think, in medicine, we're always skeptical. You got to have peer-reviewed articles and showing this versus that. But it just conceptually makes sense, in that you're going to use the thing that's already there. That why not? You put the extra thing in there, it's going to protect it. So you're getting some biomechanical, protection potentially there. You're adding the collagen, which is some biology to it, and you're doing the reconstruction. Because remember, with these players, the best chance is the first time, and unfortunately, we're going to go back, you're going to recover, and even in the best recovery, healing, everything else, you're going back to a violent sport. You're going to put pressure on that thing again. So you watch Major League Baseball. Often this person has had 2 or 3 surgeries, and it can re-tear. That's the nature of the game and the forces on the body. So if you can do this extra thing when you're at the beginning, why not? So it just makes sense to me.
This episode of Off Exit 10 is brought to you by Mark Pro, the recovery tool of choice here at CDSF. Mark Pro is a portable, easy-to-use muscle stimulator we utilize to enhance recovery, prevent overuse injuries, and ultimately boost the performance of our athletes and active adults. Unlike a traditional TENS unit, the Mark Pro doesn't just mask your pain. Its patented technology works to improve circulation, flush lymphatic waste, and reduce soreness. The Mark Pro and Mark Pro Plus are used here at CDSF and trusted by players and trainers from all 30 MLB teams. Plus, the Mark Pro offers US-based one-on-one support for whenever you need help with how to use or when to use your unit. So recover like a pro by heading to markpro.com and using code CDSF for 10% off a Mark Pro, Mark Pro Plus, or Boost Pro massage gun. That is markpro.com. Use code CDSF for 10% off your order today. The supplement industry is like the Wild West. The lack of regulations mean the supplements you purchase may not even contain the ingredients listed on the label, which is why I get my daily vitamins and supplements from Thorne. Thorne vitamins and supplements are made without compromise. Quality ingredients ensure your body optimally absorbs and digests your daily supplements, while in-house and third-party testing ensure you're getting exactly what you paid for. Thorne offers a variety of health tests reviewed by board-certified physicians that evaluate your lifestyle, gut health, sleep, stress hormones, and metabolic markers to determine which vitamins and supplements may be most effective in helping you feel and perform better throughout the day. For college and professional athletes, Thorne has NSF-certified supplements that make sure you won't get pop positive on a drug test. Whether you're an athlete, professional, parent, grandparent, or weekend warrior, Thorne's selection of high-quality supplements can help improve your quality of life. Switch to Thorne's high-quality and extensively tested supplements today at thorne.com/u/CDSF. That's thorne.com/u/CDSF. Yeah, we've seen great outcomes from it so far. From the training all the way to throwing and getting back to the mound and back to competition. Yeah. If somebody has a partial tear, sometimes in here I feel like just wish it went all the way. Get this thing done with. You'll be back. What's your course of action? Like a PRP or some type of injection?
Yeah. So that's a good point and a great discussion. Is that the study was done where I trained in LA years ago when they did PRP for partial thickness tears. And they would do the injection, and we can talk about PRP in a second. I'm no expert at PRP, but I can tell you what I know about it. With the idea that, you're trying to bring some healing into that area. It's their own tissue or own blood that you're putting in there. And then usually the protocol would be you inject it into that area where the tear is, let it, work for a period of time. Then you recover and rehabilitate. And I think the study at that time, it showed like 80% of people were able to return to their prior level. But, could you go on to tear it? Yeah, but then you're going through the longer procedure, but maybe in a certain percentage of people. I've had college players that I've done that on where they got to PRP and they're able to finish up their career. So I think it's something in our toolbox. So
does
PRP,
where the location of the tear in the UCL produce different outcomes? Like if it's more proximal and there's more blood flow, better results?
Yeah, I mean, that's the concept, So if anywhere in the body, if there's better blood supply, you're going to have a better chance of healing. Right. Same thing like if you're doing a repair of the ulnar collateral ligament, if there's better blood supply on the proximal or upper end versus the lower end. So the thing of PRP, and if everybody's all you guys are watching sports, you're hearing on, this guy's getting a PRP in his knee or that foot or whatever it is. PRP is essentially taking some of your blood, spinning it down in a centrifuge, and we have one of these machines in our sports medicine, center in Albany. And there's different concentrations of how they spin it down, of what you're trying to do. And that I leave to my partner, Dr. Shatinsky, who's one of our family practice sports medicine. I think he's been on the show
Todd's
before.
been on here before.
So
Shout
Todd,
out
we let him,
Dr. Shatinsky.
yeah, we let him
Todd
stay
may
up
have
with
seen me.
yeah, keep him up with he could keep up with the fine points of that. So I'll have him do that, and then he'll do the injection, usually under ultrasound. And what I tell patients, there's really no downside to it in that it's your own body, it's your own own tissue. Of course, insurance doesn't pay for that most of the time. So other than the cost, there's probably no downside to it.
We love using Todd for diagnostics. We're like, something's just off. I don't know what's going on.
Yeah.
I know he's non-operative, so he's gonna make a call, and then we can just refer out, keep in house.
Yeah.
He's been money.
Yeah. So we use him all the time. So he is a good one guy too. He's a lot younger than I am, but he was a big running athlete.
He didn't have to deal with Pierce though.
No.
We hired him and have to deal with him every day.
Yeah.
Mike, I was impressed. I was having some ulnar-sided wrist pain, and it had been bugging me for a really long time. And we know, Dr. Shatinsky from being on the pod, and he works with a lot of our. And I didn't want to be the person who's I'm just gonna let me email. Yeah. So I was just asking Mike, who should I don't want to bug him. He was just email, email. All right. Yeah. So I emailed Morris. I told him the symptoms I was having, and over an email, he's like, "Oh, it's probably this." Just some random thing I really hadn't heard of, and I was like, okay. But I got an MRI schedule, went and saw him. Sure enough, that's exactly what it was. I was like, that is impressive. I don't know how any of you guys do that, because I do my best to troubleshoot things myself. I'm like, I have no clue.
Yeah, Todd's great. So he's done thousands of injections probably for us over the years. And I'll tell you a funny story. But my kids were little, I remember sledding with them, and I tweaked up my knee. And
sledding?
For me, sledding. So it was just something, I was doing other stuff, never bothered me. So I did this, and I don't have time for therapy. I got to keep moving. I got this and that and stuff. So it was one of the hamstring tendons that irritated. So nothing structural, but it was still bothering me with golf or working out and day-to-day stuff. So Todd did a little injection for me in there in the one of the tendon sheets, and I've been fine ever since. So these are things that we want to use all our tools. And most things, that we deal with in orthopedics should be non-operative. But obviously we get to a certain point, and what I always say is you got to treat the patient like you want your family treated. Yeah. We're not jumping to surgery unless it needs to happen. But I like to sleep at night. So if I haven't done what I feel is appropriate treatment with the right people working on them, I'm not doing surgery. But now certain things we got to do. But,
it's
that's kind of the concept.
Yeah, as a young trainer, and maybe I was here. I don't know if everybody else felt like they were here as well. You have an ego as a young guy for sure. I feel like we're all just trying to tame our egos.
Yeah.
But you're just no surgery. Surgery is not needed. People don't. And then as you work with more people over the years, you go of course. Sometimes to return to their function.
Yeah.
You have to fix some structural things.
Absolutely.
And I think you also, when you're younger, you're avoiding saying that word because you don't want to scare your client. You don't want to, send them down a bad path potentially mentally of oh, this could be wrong, this could be wrong, this could be wrong. And you're a young trainer, you're trying to make sure you keep that client. But in the end, if you do the right thing by them, you're going to keep them. And that's just as you grow in this business or in any business and mature, you understand that.
Yeah, absolutely.
But I think that's probably part of it too, is at the beginning, you're afraid to say the surgery word because they're afraid of it and whatnot. So
as we've, myself, and I'm sure Mike feels the same way, and Paul, as someone who's working with all populations, and after doing this for a long enough time, you meet a lot of people, a lot of doctors, and you get this trust with these doctors, and you feel more comfortable referring them out to other people. Say, hey, I can't help you here.
Right.
This person is going to put you, is going to put you on the right path. And having people, it's nice to have people that we trust to refer our clients to, because we see these people every day and we care about how they're doing, and and the overall well-being, whether it's, fitness, mentally related, whatever it is.
Right.
But it's good to have the right people to refer out to in those scenarios too. Again, like we're trained. I'm not a doctor. I'm not a PT. I can do a lot of things for you, but there's certain things that, don't fall under my scope.
Right.
And we want to make sure we have the right people to send you to when the time comes, or if you ever need that.
Absolutely. I think that brings up an unbelievably important point, is that, this is kind of a team effort. Patient is the center of what's going on here. The doctor is, has to assess it properly. And I think that was one of the things we'll talk about a little bit, assess it properly, but it has to be a team thing. Patient has to be on the same page.
Yeah.
Their parents have to be on the same page. The therapist, the trainer, all these things are interrelated. And if you want the patient to be successful or keep people, out of harm, you need to have that kind of multimodal, teamwork type approach, and I think if you do that, everybody's going to be better. That's a smarter way to do it. And at some point, at the end of the day, when you've done the appropriate treatment, you've done what needs to happen, you've done the appropriate rest, because, you also can't chase your tail and say, okay, well, I don't know why I'm not getting better. Well, you're still playing X, Y, and Z, and you're still putting stress on that area that's injured. But if you get to that point and you've done the best you can, and everybody's done the best you can to maximize their outcome, and they still have some problem, then you got to go stage 2, to get to the next stage, which is operative, for whatever the problem is.
Yeah, and just getting that diagnosis as spot on as you can early is super important to get
100%.
somebody right on that right track.
Right. So that's the importance of the assessment. And the problem is you can't just rely on this X-ray or that MRI scan. I always tell my PA and my residents that are with me is you got to treat the patient, not the X-ray, not the MRI scan. If you're just, looking at the thing and say, yeah, it's this is what the scan shows, and you kind of jump to that conclusion, then you can be wrong, and we can all be wrong, even if we're doing the best we can. But, you always got to listen to the patient. Most of what you're going to figure out, if you listen to what they really tell them and ask them the right questions, you should already have your diagnosis or have a pretty good idea of what's going on. Then you have to back that up with your physical exam. What are the symptoms? What are you seeing on physical exam? And then those other modalities or other, studies, being X-ray, MRI scan, CAT scan, what have you, whatever you have to do, all has to make sense. I like it to make sense before we move forward with things.
Because on that front, you have to combine too with your imaging and your physical exam. Like, I know low back's a very common example,
right,
but you could have a disc herniation, but that's not the main driver of your symptoms.
Right.
So it's like you have to call, okay, this is on the image, and
right,
just because the structural thing is there doesn't mean that operation is the best move right now.
Yeah, and then that also brings us to another point, that if you think of, upper extremity, shoulder, and neck are very interrelated, and obviously I got a big shoulder practice, but there's a lot of overlap with the neck, and if you don't kind of evaluate both and treat them concurrently.
Tell me what's a tricky one with that interplay.
Yeah, so that's the shoulder. So you got the shoulder neck, which we'll talk about, and then you got the hip back. Those two things kind of go hand in hand. So for the most part, shoulder things I would say are more mechanical. I'm putting my arm overhead, or I'm rolling onto my shoulder, I'm trying to throw, I'm lifting, it's giving me pain in the upper arm, or it's giving me clicking, or the shoulder feels loose, whatever. With the neck, you're talking more of a nerve thing. So someone will come in and say, and they're telling me some story, say they definitely got some irritation from the nerve and neck. She's like, I don't have any neck problems. So your neck might not be the issue, but all the way the body's constructed, all the nerves that supply the upper extremity come from the neck, branch out like electrical wires. So they follow a pattern. So if someone comes in and tells me, my shoulder's killing me, but I got numbness and tingling down my arm, I know we got to start looking at the neck and shoulder, because, otherwise it gets frustrating. Okay, I give you a shot in the shoulder, you come back and tell me you're now better. Well, you're not better because we aren't dealing with both problems at the same time.
Thoracic outlet is a tricky one.
Yeah, that's a difficult one. That's a very difficult one. And even when you have a true shoulder problem, and maybe there's not as much of a neck problem where the main nerves are getting irritated, you can also get irritation of some of the nerves around the shoulder where you'll have some of these things. And all these things play a role, and we see this hugely. I do a lot of arthroscopic hip surgery. So the hip and back, so even my, high-level college players have labral tears, and this is what we'll go into that femoral acetabular impingement. even then we'll start having some low back pain. They'll have some pain in what's called the SI joint, which is at the back of the pelvis, halfway, I won't say exactly, but halfway between the hip and pelvis. So you got to, I think we've all gotten smarter, or, the therapists have taught us things. I think we know a little bit more understanding of some of the biomechanics of the body. But you got to treat all those other things if you want to be successful, especially in return to sports and things like that.
How often do you go into a surgery and you have the imaging, the diagnostic report, you have an idea of what you're going to see when you go in, but it's a bit different when you get in there? Does that happen often or no?
Not that often, but what I always tell patients is, we're doing what we can. These MRI scans, the radiologist is looking at it, we're looking at it. But I always say my eyes are better than the MRI scan. And I also say MRI scan is not a dynamic study normally. So subtle things that sometimes you may not see on the MRI scan, we'll be evaluating at the time of surgery. So, and I always have people ready for whatever I got to do, we'll do. But there's certain little things that we'll be taking a look for there.
Give me an example in like the shoulder, where you have an image and you go in and you're like, okay, a bit more complex or different than what I was expecting.
Yeah, I'll tell you what we see is, like, for example, I probably had, 2 this week where my clinical exam was that I was expecting that their biceps tendon, which, biceps tendon is in the front of the shoulder. There's 2 tendons, one that starts deep inside the shoulder, then comes out through the front. That if you have a subtle, what we call subluxation, where that biceps tends a little it lives in this groove in the front of the shoulder. If it's a little bit out of the groove, by definition, that only happens when you have a subtle tear of one of the rotator cuff tendons called the subscapularis. Usually the tendon's totally fine, upper part's torn, biceps a little out of position. And then I call the biceps the devil of the shoulder. It's not that important, but if you have pain in it, everything you do hurts, because instead of that biceps being in its normal resting position, it's already under tension. So then when you're reaching or moving, it'll give you some pain in the front. So it's not uncommon that that's difficult to pick up those subtle things. So I just had one yesterday that I clinically, that's what I thought I was going to see, and that's what I saw. That this biceps was a little out of position, and there was a small tear of the upper part of this one tendon. So we fixed those 2 things, and usually those patients they got to heal after I fix it, but they're already going to come back and tell me, 2 weeks later when I see them for the first visit, that their shoulder feels better than it did before.
When you do shoulder labrums, what makes you make the decision if a labrum tear is going to be operative or not, right? Because you can have such a wide degree of where the tear is and how much is torn.
Absolutely. So, like when I was a fellow, now this is back when I was in LA, this is back in 1999.
Did you work with any of those teams out there when you were there?
So at that time, we took care of the Lakers, the Dodgers, the Angels, PGA Tour, USC football.
What year? What year?
99 to 2000 I was there. So you go for a year when you go for these sports fellowships.
Is that like Kobe Shaq? Is that those years?
Yeah. So when I was, I'll tell you a funny one.
Oh yeah, let me hear. You got Shaq stories.
So when I was a fellow, Shaq was the main man. Kobe was, I think, maybe his second year in the NBA, so he was kind of quiet there. But Shaq ran the show. And
what year did Shaq get to the Lakers? He went the Magic to them.
Yeah, I don't know years on it.
I want to say it might have been 98 or 99 was when he.
It was 99. I was there.
Yeah, I'm trying to think of when he went there.
Yeah, so this was back in the old
Google.
day. Yeah, look it up. Look it up. They used to play in the Coliseum, and so there's a small little. I mean, if you see these training rooms now at the professional, this thing wasn't all that fancy there. So there's a little, locker room, and then the training room. There was, probably from where I was sitting here to where that end of the wall is there. So not a big room. And so what would happen is, for these games, the doctor that we used to work with, who was the head doctor, would be there, and then one of us fellows. So we'd, take our turns in there. So I remember, that all our pictures would be up on the wall like a composite with all pictures, with all our names on the thing. So Shaq was, kind of running the show. So he'd like to pretend he remembered everybody. So he'd look out and he'd look up. I see him look up on the wall at the picture, and he said, "My man, Dr. Das is in the house tonight." So then he talking about is this problem, that problem. But he was like, you see him on TV. That's how he is. He's totally engaging. The year I was there was the year of the NBA lockout. So then they had to get physicals to go back. So I remember examining Shaq's knee it was like a tree trunk. He was unbelievable.
Shaq was signed by the Lakers in '96 after they like 4 months or 5 months after they drafted Kobe.
Yeah. So it was an interesting time. It was fun.
You worked with Kobe too?
Yeah, Kobe. I remember. He was just on point and focused kind of guy. That year with that lockout, Dennis Rodman was there on that team, and he kind of just kept himself and he would do his thing. But he was fierce competitor and things. So it was a fun time. It was good.
Do you have a favorite athlete from like your time out there that you just enjoyed working with?
I mean, that Shaq thing was right, but look, we had a lot of exposure to the Dodgers because the way the fellowship works is you were there at the beginning of one season, maybe the end of the other, or vice versa. So I remember another memorable thing is that you would one fellow would go down to Dodgers training, and at that point, this was when it was still in Florida. Now they're out west, but this is in Vero Beach, and my son and Matt played at that same place, place in Vero Beach. It's a nice facility, but it's there. So I spent a whole week there during spring training, and it was at the beginning, I think, when the pitchers and catchers are with Dr. Job. So you're going to see the players, you're seeing the minor league players, and then every night you're going out with Dr. Job. He take you out to dinner with the local doctor. So we had a lot of fun with that, and there's so many players that we would have, and luckily they took a lot care of a lot of other teams too. Like for example, I can remember the soccer team that was there,
MLS.
Galaxy, Galaxy, and then we also took care of the LA Kings and the Mighty Ducks. So there's exposure to all kinds of stuff. It was fun time. It was a great year. That's what I tell people, my residents. Hopefully we're training you well to do things, but nowadays in orthopedics, most people that graduate do an extra training, be it in spine surgery or hand surgery or sports medicine or total joints. And it's good to go somewhere else, learn somebody else's perspective, and get that knowledge, and then, incorporate it in your practice, how you think is best.
Is it like the sports world where people are just getting more specialized, which is good?
I think it's been several years. I mean, starting back from I would say, we have 5 residents every year, and I would say over 90% or 95%, maybe even now almost 100%, everybody does an extra year of training, where they pick what they like, and you got to pick that, when you're still in your residency. So I think like 3rd year in your residency, and you're going to be there for 5 years, you're already thinking ahead, and where you're going to go. So we paid for it. So, for example, I've sent probably 3 people to L.A. to do the sports fellowship since I've been in practice. So I keep in touch with my guys in Los Angeles, and it's nice to send people there, and they're happy, they've done well, and it just kind of perpetuates it for us.
Yeah, I think it's nice to get away from here too. And even like Rochester, but like I lived in Boston for a long time. Paul's in New York City, but it's just like get away from here.
Yeah, there's nothing wrong with some sun either.
Nothing wrong.
We had a great year in LA.
I'm trying to remember there was a doctor's office I used to walk by all the time, and you could see through the window there was a Kevin Durant jersey.
Yeah.
And somebody, I can't remember what doctor it was, but I was like, yeah, he definitely worked on all of those. It was like 4 different jerseys of like big name players. I distinctly remember Kevin Durant's jersey in there, and I was like, this guy's definitely an important doctor. Definitely important in sports medicine.
Yeah. So LA is a little bit different than so we were also, you got this actor coming in, you got that person. So it was a lot of fun there. So for a year, it was awesome, and learned a lot. And but one interesting thing I'll say, Dr. Job said to me one time, he said, if you're still doing things like I taught you, then I haven't taught you anything. Meaning that obviously we all think of ourselves in medicine as scientists. We want to think, build a better mousetrap. So even things that I've done thousands of times, surgeries, I'm always trying to think about, okay, how could I do this better? What could I do a little bit different? What if we do this? So you always want to be, and that's the fun of medicine, or at least for me, the fun of surgery, is I think you asked before, sometimes you get surprises. Nothing's, you always got to be ready, and you got to have more ways to figure out. So if this, you get, presented with this problem, you better have 2 or 3 ways that you figure out how to take care of it, because the patient's, under your care, you got to, the buck stops with you. You got to take care of it. Which is fun. I mean, it's, it is, there's obviously stress to it and puts you under pressure, but, that's what we like. So.
I just found that doctor. It's Dr. Martin O'Malley. He does foot and ankle. He did his Achilles.
Yeah. Oh, yeah.
And I only realized it was him because the address is literally a block from where I lived.
Oh, really?
Yeah. And I 100% remember walking by it, and I was like, I bet you I can find this pretty quickly.
Yeah.
Yeah. Dr. Martin J. O'Malley.
Yeah.
Apparently he's a Bigfoot guy for Achilles.
Yeah. So New York?
Yes.
Yeah.
Yep.
Yeah.
How'd you then settle into like, this is the set of surgeries that I do?
Right.
These specific ones.
Yeah. I mean, general, if you think of sports medicine, you're dealing with shoulder, knee for sure. Then if you've had some training, not too many people get to training for the elbow and Tommy John and all those things. So obviously being with Dr. Job, that was the ultimate training, so that's where, I had interest in that. And then when I first started practicing, it's been many, many years. One of my former partners was one of my mentors that said, this hip arthroscopy thing is going to be big. There's only a couple people in the country doing it. You should go look into it a little bit. So at that time, when I first started practicing, this in 1999, the doctor that, is now probably, very well known for it, Dr. Philippon, at that point, he was in Florida. So I went down and spent some time with him, and he's in Colorado now. And, so I've been through the evolution of arthroscopic hip surgery because that's a tougher joint to get into. Shoulder, knee has been going on for years. The hip at that point, not too many people were doing it. And at the infancy of the thing, it's because, companies weren't putting money into the technology and what we can do today compared to what we could do then. And we help people, people felt better and we were able to do stuff. But it's kind of night and day. So there's been huge evolution of what we can do in a hip now, what we could do 20 years ago, or let's say.
You're talking about labral repairs primarily?
Yeah. So what for the most part, there's a few other things they'll do, but, for the most part, what we're talking about when we're talking about athletes is the condition called femoral acetabular impingement and labral tears. So FAI is a thing that, beforehand, not too many people knew about it. I think people are much more educated. They're on, looking into this. They have, my brother had that, or my sister had that, or, I know somebody who had this problem. So it's not like when I first, years ago, I had patients come to me, this has been going on for 5 years. I've been to 6 doctors. I don't know what's going on. And then we came and saw you, So I think just in general, people are more educated about it. So, and be it the primary doctor, be it the trainer, be it the athletic trainer, physical therapist, they're like, hey, I think you got this, and then they ship it.
How much is just that fact and the just better imaging that we have just lead to more diagnosed cases of these things and then more surgeries just because we can catch it and diagnose things better?
Yeah, I think that's a huge component. It's like having the index of suspicion of saying, I think this is what we got. Having people who can evaluate it, get that, work it up properly, get the right imaging for it, and then, thankfully we have good answers for it now.
So with FAIs and labrum tears, do you almost always see a cam or a pincer like overgrowth?
Yeah, pretty much. We like to put them in these boxes where cam or a pincer. So
explain what that is.
Yeah, absolutely. So what I've described this FAI is that it's kind of like a nutcracker effect. Certain percentage of people, and there's probably millions of people have it, and probably many don't know they ever had it, because if they're not doing certain activities where they start having some problems and symptoms, then they may never seek any medical care. So it doesn't mean just because you got that impingement doesn't mean you need surgery for sure. But if you have this genetic thing or component genetic thing and you have a prominence either on the ball or socket side, so cam impingement, CAM, is a prominence or a little bump on the femoral side or the ball side. Pincer impingement is either a angulation or prominence on the socket side, to kind of put it in simplest terms. And if you are doing some type of activity, usually a running activity, jumping activity, then someone who has that genetic predisposition has a higher chance of tearing the labrum. And like I said, you may never know anything about it, but if you tear that labrum, then you might have some mechanical symptoms, catching, clicking. You may have some pain. And then when it really gets inflamed, your hip says, hey, stop doing this to me. So simple stuff, getting in and out of the car, up and down stairs can bother you. And then, as we talked about before, the body's a machine. So consciously, subconsciously, you don't want to have pain. So your body, you're trying to play X sport or whatever, says, how can I get through this? So you may change your mechanics, you may change your gait. Next thing, you're putting stress on the low back.
Yeah, we see it a lot with rotational sport athletes, baseball, softball hitters.
Yeah. Yeah. So usually it's some form normally of running type thing, but I've, treated, martial artists, golfers, runners for sure, so like one of the classic ones in the non per se athlete is somebody who said, well, I want to run my first marathon or I want to run my first 5K. Maybe they're not in the best of shape. They start doing this, and then next thing they start having some trouble, so.
This episode of Off Exit 10 is brought to you by Bombas. Bombas makes my favorite pair of socks, hands down, alongside the most comfortable and durable underwear, t-shirts, and other everyday clothing staples. Their wide variety of sock lengths, colors, and patterns have you covered, whether you're working out, going out, or lounging at home. I love their merino wool blend athletic ankle sock for long days of coaching at CDSF and getting in workouts myself. And if I'm at home doing work around the house, you better believe I'm wearing my Bombas Sunday slippers with their comfy memory foam midsole. And when you buy from Bombas, you're also buying for those in need. For every item you purchase, Bombas donates one item to people in overnight shelters, transitional living facilities, rehab centers, Title I schools, and medical service professionals. Take my word, if you want to upgrade your sock game to one that's more comfortable, durable, fashionable, and charitable, head over to the Bombas link in this episode's description to browse their full collection of everyday wear, and don't forget to use code CDSF20 for 20% off your first order. This episode of Off Exit 10 is brought to you by Anchor and the all-new Anchor Pro, crafted to endure the most high-performance workouts without the high cost and space requirements of a standard cable machine. Named the best portable cable machine by Men's Health Home Gym Awards, Anchor provides the full functionality of a cable machine in one small space-saving unit. Designed with user-friendliness in mind, Anchor can simply be attached to any squat rack or placed on any wall in your home gym using its intuitive sliding track mount. With up to 65 pounds of resistance, Anchor is built for high speed and controlled exercises alike, from cable presses and rows to chops and lifts. The Anchor has been a game changer for us here at CDSF, and now you can enjoy the same professional quality cable machine in your own home gym by heading over to anchortraining.com and using code CDSF10 for 10% off your order today. Get all the benefits of a cable machine without the high cost and installation fees. Enjoy the portable luxury and space-saving performance of Anchor today by going to anchortraining.com and using code CDSF10 at checkout. That's anchortraining.com, promo code CDSF10 for 10% off your order today. This episode of Off Exit 10 is brought to you by Drink Alchemy. Fatigue and brain fog affect us all, destroying everything we pursue. Whether as an athlete, artist, creator, or entrepreneur, our mind holds the key to performing optimally. By combining the most potent organic nootropics found in nature, Drink Alchemy delivers sustainable boost to creativity, memory, energy, and focus in one epic beverage. Stop pumping your body full of excessive amounts of caffeine and unknown proprietary blends from other energy drinks, and get clean energy from Drink Alchemy's natural nootropics like lion's mane, L-theanine, and caffeine from green tea. Used by Olympians, D1 athletes, MMA fighters, and entrepreneurs, Drink Alchemy has become a huge part of my daily routine, making sure I'm functioning optimally during long days of coaching athletes, running CDSF, and getting in quality workouts myself. So do yourself a favor and ditch the energy drinks loaded with caffeine, other stimulants, and who knows what else, and head over to drinkalchemy.com today. Live with your mind unbound and save 10% off your order by using code CDSF at checkout. That's drinkalchemy.com, promo code CDSF for 10% off your order today. Yeah, or even because in our world, a lot of kids do lifting programs at school now, which is great that they have access to it.
Right.
But a lot of them are structured as like powerlifting style programs.
Right.
Old school football lifting program.
Sagittal plane, heavy squats, heavy deads.
Right.
So we see these things in kids get exposed from like being exposed to those large amounts of loads. Like if a kid has a camera pincer and they're slapping 300 pounds on their back and driving into a deep squat, it's like that's going to expose that.
Yeah.
Or low back, or you name it.
Yeah, absolutely.
So we see it there as well. How do you know then to make the decision and that standpoint if a labrum is surgical or to try to go the conservative route?
Yeah, the issue is if they're having some symptoms and have a proven labral tear, usually on an MRI scan, MR arthrogram is what we use, then unfortunately, once you tear that labrum, I tell them this is not a life-threatening problem, but the biomechanics of the joint, because you're putting weight on this, even if you're not necessarily running on it anymore, because a lot of times when people have this, they're like, I stopped running, but it's still bothering me, is that you can do a little damage to that cartilage, So just, from my experience, I don't know how many hundreds or thousands of these procedures I've done over time now. It's been a lot. That I've never seen anybody from 16 to 60 that had a labral tear, hadn't done a little damage to the cartilage. And what we hope is normally that the cartilage on the femoral side or the ball side is totally perfect. Cartilage on the socket side is only damaged in the upper portion adjacent to the labrum. So that then we just kind of give them a little haircut, trim up a little of that cartilage, and the hope is by fixing that labrum, and the way I fix it is I put these stitches in there that are permanent, and like the same kind of material that they use in that internal brace is this super material, and then tack it down or repair it with these plastic anchors so there's no metal in there. But the concept is you can't do half the treatment. You want to just go in there, fix that labrum, and have that thing, the conflict from the ball and socket, which is the impingement. So what's nice with the arthroscopic, I can take it through range of motion. We don't go crazy, but trim down some of take the conflict off by trimming some of the bone on the ball and or socket side. So I don't think I fully answered your question, is that we try to put it in these boxes. It's cam, it's pincer. In my experience now dealing with this for 20 plus years, it's everybody when they have it usually has a combination of both. This one may be more cam, this one may be more pincer, but usually in my experience, it's some degree a combination of both of those things. So I tell the patient is, we're doing comprehensive treatment. We got to fix the labrum. We're going to clean up the cartilage. Once the cartilage dam is done, it's done. I can't take it back. I can't turn back the clock. But we can trim down some of the prominence on the ball and or socket side, let the body heal, recover. Then you need, again, the team approach is critical. Surgery is critical, healing's critical, therapy is critical, strengthening down the road is critical. So all these, players have to be involved per se to get the athlete back.
Because if you don't repair it and the cartilage continues to get damaged more, you're just heading on the line towards a hip replacement one day.
Yeah. The hard part is this: is that I say we got a window of time to do it. Again, this is not life threatening. If you don't do it, suddenly something bad's going to happen to you. But if we get to the point where there's too much cartilage damage, then me doing the arthroscopic might be too late. So you might be in a gray zone where it's too early for anybody to want to do a hip replacement, too late for me to do the arthroscopic.
Because so much cartilage is damaged where you're still going to be in pain.
Yeah. So, a younger person, even they got some cartilage damage, we're going to probably push the envelope rather than say give up and just go get a hip replacement. Mm-hmm. But, so that's the kind of the major concept with that thing.
I feel like we've had a couple of our adults that were in that in between, like, we're not going to do surgery, but you're not quite there to be a candidate for a replacement,
right,
and whatnot. And then sometimes if the patient pushes the envelope enough, so you might find somebody that'll do that replacement a little sooner, so
right, yeah,
you can feel better and whatnot, especially if you're in a lot of pain,
right. Yeah, I think one thing though, you guys asked me, so the other area is, so if I have a younger person that has a labral tear and they have open growth plates still, one other option I'll give them is I probably is not proven that it's going to do it, but there's no downside of trying the PRP injection. Mm-hmm. Target it into that area under ultrasound guidance. Give it a try. Maybe that could work.
Right.
Or maybe it can help.
Yeah.
Mm-hmm. Yeah, and then I think you brought it up a little bit, but just the timelines of return to play, right? Because you have, from a research standpoint,
it's really funny. That was the thing I had highlighted.
Yeah.
To ask you next.
Here we are.
So here we are.
Okay, we see this a lot.
Sure.
In terms of, because we'll get kids in here pretty early, let's say post-op or during injury, because we'll just train around it. Let's let this heal. Let's train other body parts, make sure we're not loading it, and then in conjunction with PT, gradually start to reload that area. But because if you just look at research and timelines, somebody should be cleared, let's say, at this month.
Right.
But from a biomechanical and a performance standpoint, we are like, you are not ready to go.
Right.
You're at an increased risk, even though the research says this.
Yeah.
It's sometimes hard for us to relay that to a kid or a parent because they go, oh, well, doc said I'm cleared.
Yeah.
We're like, well, we still think you're at an increased risk.
Yeah. So it makes it a difficult situation. So what I'll say is, you got to individualize, and the bottom line is just because our research studies say, you should be ready to do X, Y, and Z, you're still dealing with a human being. They have to reach certain criteria and do things. So, for example, let's just say for, ACL reconstruction, for years we would do the reconstruction. We'd say, okay, you can go back at 6 months because we think things are strong enough if you do your rehab and all that. And then that's evolution that we've found that probably athletes now are maybe not only physically, but not maybe mentally ready to go back to that level, unrestricted. So we've pushed our timeline to say, well, we're going to go more like 9 months, you know, and you got to treat the whole body. So these are important things. And what you just said is huge. And that the other thing, for example, let's say the hip. Someone's been living with this thing for 3 years, you know, been bounced around or didn't complain about it, never got it evaluated, whatever it is. So your body has gotten into these bad habits. So when I tell somebody with that, or they also have some back stuff, I said, you know, I'm going to fix it. We have our timelines of what I do for my rehabilitation afterwards. You got to meet certain criteria before we're even going to think about doing any running activities, because, you know, you got to walk before you run type thing. But if your body has been in some bad habits, the therapist's and trainer's job is to help you maybe undo any bad habits or compensation. So I might tell that person, I expect you're going to be longer than this 18-year-old, you know, Division I player that was in perfect shape till they had this problem and hadn't had enough time to get out of whack really with the thing.
And I think just even like for kids in here too, if they look at professional athletes, you know, you'll have one professional athlete with an ACL come back, you know, on a short timeline. Adrian Peterson, for instance, like it was 6 or 7 months.
Right.
And then you get somebody else that takes them 14 months.
Right.
And it's like, well, it's all different depending on the person and where they were before the surgery and where they were after surgery, how bad the tear was, did they have any setbacks? Like so many things go into it. And I think that's one of the things that, you know, you get quote unquote like the cleared to play, but we got to make sure you're ready to get it back out there and actually perform too.
Absolutely. So I think that's where the team approach is really critical. So 100% of the time, anybody that ever has surgery with me, I give them their op report. I give them, if it's an arthroscopic thing, their pictures. And I say, I want you to bring this to the therapist so they can read it. They know what I did. I don't want any miscommunication. They know exactly what I did, what I found. Here's my official report. These are the pictures, you know, and it just, you got to engage the patient, and I got to say their family. So I just, you know, today I was here in the office this morning. I'll go back later, but you know, I probably had 3 or 4 surgery discussions, and I always say I like to have 2 sets of ears because I'm going to tell you a lot of stuff. You're going to hear surgery, things are going, something's going in one ear, out the other. You're, you know, overwhelmed with this. So it's always good to have, you know, a champion in your court, be it a family member, spouse, whatever it is, that, you know, also hears about what you're going to go through. This is what we're going to do. And then I also, like, anytime I do a surgery, I like to sit down with the family because that patient's out of it that day. I remind them a few things before I go in. But afterwards, I like to sit down with the family or whoever's with them. I have an instruction sheet because the same thing, you know, everybody's overwhelmed with things.
Right.
And if you engage people from the beginning and get, you know, more than one person involved with this thing, then the results for an outcome, I think, are enhanced. You know, so that's kind of critical for me.
Yeah, that's a good point. Yeah, but I think too with just the rushing to return, it's like kids are feeling the pressure. Back to our original point, we're like, I can't miss time.
Right. Yeah. Yeah. I mean, as we talked about, people are getting more specialized now. If I've missed this season, you know, this was my opportunity to make that high school team. Now it's gone, or what have you. You know, or recruiting for college or what have you. But I'll say, you know, no one has to be hurt. But at some point, if something needs to be taken care of, you got, you know, we're not happy about it. You got to deal with it. You know, now it's a bump in the road that if we take care of it, we recover it, then we'll, you know, progress you back to play. Yeah. That's our goal.
Are you giving throwing programs post TJ and shoulder injuries, or is that a PT's role?
Yeah, PT. I mean, I have my throwing protocols, but I have certain therapists that have done it for me for years. That, you know, you know, I'm no expert at physical therapy and knowing the nuances like you guys know about muscle imbalance and all that stuff. So I'll keep an eye on things, but I will say there's no substitute for experience. So, you know, patients will tell you, well, I had my surgery. I can do the exercise on my own. I've did this and that. And for some things, maybe for the most part you can, but that's what I tell them. There's no substitute for experience. So go on a couple sessions for certain, even if it's a minor thing. Learn what the thing is and let the therapist teach you some things. It's helpful because a lot of times they'll identify, you know, your knee problem. Part of your issue was you got a gait problem relative to your back. So if we can work on this, maybe we're going to optimize you overall in the future.
Right. Yeah, because, you know, getting that professional set of eyes to help you guide you through even those first couple sessions. One, they might see something that goes, hey, we need to really like hammer in on this.
Right.
Because there's an imbalance from something before the surgery that you had because you were compensating, or just so you know exactly what the heck you're doing and to get some different eyes and
ears
absolutely.
I mean, you guys have trained eyes. You're going to watch somebody do a squat and say, hey, they're not, engaging their posterior chain. They're using the quads more, so they're going to be, at risk or not ready to go back to doing, cutting sports or whatever it might be,
Yeah. Yeah, and we see too on the other end too, kids with like so many cooks in the kitchen.
Mm-hmm.
It's like I'm going to.
Yeah. Right.
That's
right.
a whole new thing.
Yeah, that's a whole different game now. Yes, for sure.
I think when you got the right people and cooks, quote unquote, in the kitchen, like for each thing, like that's where you're gonna optimize your success from a rehab perspective, and then leading into a performance perspective is, making sure you have, everybody's communicating. I think that's the biggest thing that you talked about.
Right.
Which for us is like one of our biggest things is like, we get somebody who's going to physical therapy, maybe they're a brand new client. It's like, okay, where are you going? And we always try to reach out. Sometimes we get people that reach back out, and sometimes you don't. And then if you don't, you do your best with that,
right?
And everything, and try to make sure that the person that's coming in is, communicating with you what they are doing at PT if you aren't able to contact them.
Yeah. So what you guys are doing is, obviously you do a surgery, you got to do your therapy, the body's got to heal, and you do things. But then at some point, then you got to get ready to get back to play.
Mm-hmm.
Right? So that's where you guys come in, where, okay, we're going to make sure we don't have muscle imbalance. We're going to figure out how you're going to be safe to return. Maybe you got some deficit in X, Y, or Z that we got to work on to get you back, So, we didn't have all this stuff back in the, old days. So it's great.
This is
awesome.
a new thing.
Yeah.
It's like this. I started doing this in 2010, and I feel like that was kind of like very early on in terms of places like this, like a private strength and conditioning facility.
Yeah,
growing up, we didn't have it. Did Pierce? You had you had places like this or no? Growing up, no. I mean, it's that new.
Yeah, right. I mean, it's great. I think I first met you when I was giving a lecture to the therapist at
Marshes, right?
Yeah, sometime back.
Yeah.
And have the interaction between the therapists, the trainers, the doctors, what have you. It really,
I miss Marsh. He's down in Delmar now.
Yeah, he's down there. Yeah.
We don't share people like we used to because we don't get that draw from down there.
Yeah. So, but that's his hometown, so he's happy being close to home down there. So it's been good.
Yeah, Marsh. Yeah, I forgot that you did. That was a hip. That was a hip repair presentation.
Yeah, it was years ago.
Yeah.
Wild.
I forgot about that. Did you ever feel the pressures as a parent with like your kids growing up in terms of like I need to get them in this or that team?
I mean, we always try to do stuff that that they like. Now, my son Brandon, who's good friends with Matt, he was pretty gifted in all areas, so he was able to pick up a bunch of sports. He played basketball, football, baseball, but there's so many time constraints. So I always was, anytime you're talking to any athlete, what percentage is really going to go on to college, what percentage is going to play professionally. Obviously, it's a small number. So if you can enjoy it as best you can, and it's hard because as you get more pressure as you go up, sometimes you're not enjoying as much as you did before, because now you're feeling this pressure from this and that. And, at the end of the day, like I'll tell players when they're coming to see me, they're planning on, these are high school kids going off to college. And I tell them and their parents, what I would suggest to you, I've been doing this for a long time, that if you're going to go play at a certain place, make sure you like that place. If tomorrow you go there, you don't like the players on your team, you don't like the coach, you don't feel like you want to play anymore, would you still be happy at that school? So when you're figuring it all out, if you got both those together, then it's great.
It's awesome because that's like the same thing that we preach here with like, hey, God forbid something happens. You get burnt out, you get an injury, you can't play anymore. Are you still going to want to be there?
Right.
And I use Mike sometimes as an example because if somebody had told me Mike would have only, what'd you do, 2 years and a fall for baseball?
2 years of baseball. I was obsessed with baseball,
Yeah.
but
Like,
I put a lot of pressure on myself.
If you told me Mike was going to only play 2 years of college baseball and not go all 4 years, I would have been like, no way.
Yeah.
No way.
Yeah.
But like things happen.
Yeah.
Life happens.
A lot of things
you start to go, well, I have other things I want to do, and this is taking up more time than I want it to, and it's not worth it for me.
Absolutely.
So, making sure you know that you're at the place that you want to be and that you got the support you want to have.
Absolutely.
So I love that you stress that with them, especially like the kids that are like, maybe going through an injury and going off into college, and it's like, hey, let's make sure you're picking the right spot, that you got the support you need and everything too.
Right.
You also oversee a lot of doctors as part of your job?
Yeah, I have my own PA, but I'm involved with some of the training with the residents. So like I said, it does through Albany Med that there's 5 residents every year, and they're training with us, doing things in the hospital, but they come out to the surgery centers, or there's always somebody on a sports rotation where they may be seeing patients with me in the office. They could be coming into surgery, and you always like that. It's good to keep kind of up on things, be things that maybe I don't do all that time, but be up with the trauma, how things are changing, and all that stuff. So it's nice to be involved with young people where they're telling you about new stuff that's going on. Like I said, you always gotta this should be a lifelong process. So it should always be some evolution as you go through your career.
Yeah, I think what you said is like what Job told you. Like, if you're doing things how I showed you in the future, you're doing something wrong.
Right. Exactly. I mean, we all try to, you don't want to just say I do it. And I always am big on when I'm, training residents is this is why I do this for this reason. Now, I don't want to be telling them I'm doing it just because I like doing this and this is how I've always done it. So this is why I do this, fix this way. This is why I like to do that. Now, that's my opinion on what's worked best for me. So, but we always have to have some thought process. Why are we doing this? Why are we doing it this way? Could we be doing it a better way? And that's the fun of the profession and surgery as far as I'm concerned.
What's something right now you're doing where you're starting to see change? Now, we talked about the Tommy John already. Like, this surgery I've been doing for so long like this, there's now newer research. We're now doing it a bit differently.
Yeah, so that, like, for example, you'll see now, you guys are probably seeing it here with some players you treat, that there's some evolution on ACL reconstruction. You're seeing more quad tendon reconstructions. Maybe you haven't seen it.
Yeah, we've seen some. That's always because I always refer to, like, work with, like, the Suarez team and Allison, or like Sam Arnold at Nicola, where you have parents ask, like, what's the best graft? And I'm like, I honestly don't know. We've seen success from all of them, and we've seen setbacks from all of them.
100%. So there's a lot of factors that go into it, and so like in anything, we try to go back by science that this is and concepts. So for example, the quad, you think it's a good tissue. You can get a pretty big graft out of the thing, but time will tell. So so far I think there's still good options for the ACL, but there's always evolution, and now we're adding some biology to it. For example, some of these soft tissue grafts, I'll use the internal brace like we talked before. Meaning that maybe we're taking a little stress off the repair. There's also been some changes on. There was an old procedure I used to do, before even my time. For ACL, they didn't have the arthroscopic surgery, so they weren't doing the reconstructions like all you guys have seen this. So this is even before my time. So they would do some what we call extra-articular reconstructions, where they would take some tissue and do this and that and give you some stability. So now there's some evolution of this, what we call, you'll see maybe people, if you're getting your op reports, it says LET, lateral extra-articular.
We're seeing that with ACLs, and we've seen great outcomes with that with ACLs.
So the LET is doing an old school procedure and adding it to the ACL. So for example, if someone has a revision, someone's had ACL, whatever graft, they've retorn it, then the thought is by adding that other portion of the procedure, which I can explain in a second, will give you some rotational stability and take some stress off the graft. Or if I see somebody, I'm looking at their other knee. So you hurt your knee, you're going to be a little stiff. You go to therapy to get optimized before surgery. But if we see your other knee that is not injured, has significant what we call hyperextension, goes straighter than straight, those are ones that I may be thinking about adding to LET. So you do your reconstruction. LET means you're taking a strip of tissue that's on the outside of the leg, your ITB, attaches down near to your knee on the outside. So we leave it attached near the knee, take a strip that's about 8 centimeters long, 1 centimeter wide. So now we got this strip that we put some stitches in, kind of weave it around in a certain position, and then reattach it to give us some rotational stability on the thing. So another incision on there, but we do find it, I think, in the revision setting. And if you don't want to do everything all the time if it's not necessary, but if there's certain things that we think are going to enhance our, outcomes and take some stress off the ligament, then, I think it's something that's good. And that's why we always want to have studies. And like you said, we're doing things differently today in some ways than we did, 2 years ago, 5 years ago, 10 years ago, It's also, I do a lot of shoulder replacement, and the evolution of doing these low radiation 3-dimensional CAT scans has been revolutionary. for these, when we do these, you guys, you don't probably have 70-year-old athletes coming in here, but we probably got some. But this, what we call reverse shoulder replacements, made for usually an older person that, or someone doesn't have a rotator cuff. So when we say reverse, we're putting the ball on the socket side, socket on the ball side. And, a lot of times you're doing it. I, just saw a patient this morning. This is probably, as I had arthritis for years, you start getting some deformity in that joint. So this three-dimensional CAT scan gives us a lot of great information. So it's essentially we're virtually kind of doing the surgery beforehand. So 100% of the time I'll use that CAT scan. We'll have a plan where the bone is good, what kind of components are we thinking, and we bring that CAT scan in the operating room when we're doing it. And I think it's really, helped us with that specific procedure. It's really been good.
You'll do PRPs. You refer to Todd for PRPs.
Usually I'll send it to Todd. He's done it, many times. We got the machine that's right there, so he can do it, and he does a great job for us.
You see a place for stem cells too, or no?
Yeah, he does some of that. I haven't talked to him recently about it. I think he's even for arthritis, he's been pretty happy with doing the PRP, but he will also do the stem cell where, you're taking some of the material from the patients, usually at the iliac crest, which is at the pelvis, mix it together in some fashion, however he wants to, and then it will inject it.
Because I feel like some people think that's like a magic
thing.
Unfortunately,
there's no magic to it.
Right.
But I think if it's you're doing no harm and it's making the patient feel better and maybe improving their ability to do whatever X, Y, and Z. So I don't like to, I got people that are active at 70, they're still playing baseball at 75. So I'm not gonna say, well, you should just go sit around and
they're
do
playing
this and
baseball.
that.
That's gonna be Dan.
Yeah.
It's gonna be your dad.
So
I know people playing baseball at 75. It's crazy.
Yeah. So it's interesting.
Well, and I think that's a good point too, is like, obviously surgery when it's necessary is needed, but like we are also in, us and you are in the business of making people feel better and move better. And like, so if you're feeling better from something simple and it's allowing you to do everything you're supposed to do and we don't need to do a surgery and it's gonna, you're not gonna do any more damage or anything like that, then why not go the less invasive route and get them feeling better so they can go still play baseball at 75 or whatever they're doing. Flag football at 55, like I probably will be.
Right.
Does the perception that some people have that surgeons just want to do surgery drive you crazy?
Not really for me, and because I know that's not how I can't speak for everybody else, but like I said it beforehand, I like to sleep at night. I want somebody to be treated like my family. So if you're jumping to surgery, it's going to bite you at some point. You're going to, when we go into operating room, we know risk of infection, blood clots, all the stuff. If you do not respect that and treat things, properly. So I like to have done whatever I can do non-operatively. And like we said, majority of stuff, every week I got, about 50 people coming in, but they got shoulder tendonitis. We're going to initiate some treatment, might be a cortisone shot, physical therapy, and then they get educated by the therapist, and then they do their thing, So we're not jumping to any surgery for that. And but if you get to the point where you've done everything and the patient's got to be engaged with it, are you doing what you want to do? Maybe you're not trying to go run a marathon and you feel happy that I'm going to stop doing that thing that was bothering me, even if I got this tear or that, and you're happy enough, leave it alone. If you're not, and you're not doing the things you want to do, then we'll start talking about surgery and the risks and what the recovery looks like.
I still remember going into for my Achilles surgery. Didn't know you could go without having surgery. And, doctor goes, so these are your options. We can go the surgical route, but, tells me all the details. And he goes, or we can go non-surgery. And I was like, wait, non-surgery?
You were fully torn?
I didn't have an MRI because when I went to the urgent care, I basically told him, I was like, pretty sure I tore my Achilles. Like, same conversation I had with you. They laid me on my stomach.
Yeah.
Felt my Achilles. Like, okay, we're going to send you to Dr. DePretta. And so then I went there, and I'm assuming when he went in, and like you said, eyes are going to show you more than an image. So he was like, all right, goes in. So I don't know. I don't think it was fully torn and whatnot. But at the same time, like he's like, yeah, so, you can do this without surgery. And I was like, doc, I'm trying to play flag football still. I have to coach people at a gym and jump and run and stuff. Like, I got to have surgery.
Yeah, you definitely
like
need that.
So it was one of those things like, I appreciated the fact that like he gave me other options that I didn't even know were there.
Yeah.
As far as that, because like again, I think of Achilles, I think of every athlete I've seen with an Achilles, and it's like, oh yeah, going to have surgery.
Yeah.
And like when I felt it and had it happen, I've told Mike and other people, like, fastest flip in my head, switch in my head was like, all right, well, I'm gonna have to have surgery. I'm gonna have to go through physical therapy. It's gonna suck for like a year, but we'll be done with it after that. And been smooth sailing since.
Yeah, absolutely.
Do you ever see, someone comes to you, oh, I have show some kind of shoulder pain. You say, all right, there's either some kind of tendonitis, or maybe they have really small, kind of really inconsequential tear for their style of life, but they still have pain. You say, all right, I'm going to send you to PT. They go to PT maybe once a week. They do their exercises there. They never really do anything else.
Right.
They come back still having pain. They tell you they're doing all their stuff at home.
Right.
They have surgery, and then they don't realize that after you have surgery, guess what you got to do for all this time?
Yeah.
Is that something you kind of consider while you're talking to somebody, or do you have an idea of whether or not they actually did the other stuff
if they
first
really
when you
did
see
what
them?
they were supposed to do?
Yeah. Does that make sense?
Yeah. Well, so, and I think you asked me before, Mike, I might not have mentioned it, talk about it. So when I was, a fellow back then, pretty much everybody in the country would be coming out to LA. We'd be fixing labral tears and baseball players, all the time. Then the evolution came over time that maybe 70% of those players were going back to the same level. So then the pendulum went a little bit that, not every labral tear, I think you asked me that before and I didn't answer, gets surgery on it. So now kind of the treatment thought or algorithm is that, if you have a diagnosed labral tear, the treatment is physical therapy, progress to a throwing protocol. And if you can't do it at the same level, and we've done everything with that, including what you just said, because, you can't go through the motions. You can't look at a video and figure out how to do it because there's no, substitute for experience. If I'm telling you this is my range of motion, I know about it. I can't tell you. You'll be able to look at it and really, assess it better, looking at it. That, people shouldn't look at surgery as a quick fix. You want to have tried everything you can. And if you put in that effort, you better put in that effort beforehand if you want to have the outcome afterwards. So this is just, again, educating the patient, getting them engaged, and being responsible for yourself too. So if we maybe get through this rehab properly and get your strength right, maybe you're not going to need surgery, because once we pull the trigger and do surgery, then we got to do it right. You can't just do it halfway. So once we do it, we get the therapy, we got to heal, we got to let biology, can't change biology. And you got to get the right people to start the recovery for the therapy and then progress back to, strengthening and everything else down the road.
Mm-hmm.
Yeah, 100%. Das, I appreciate you doing this, man.
Yeah, man.
Yeah, no problem.
This was
My
awesome.
pleasure. Yeah,
Glad to finally put a
great.
face to the name and everything. So this was a lot of fun.
Yeah, man. No, thanks for doing this. I appreciate your time. I know you're a busy man, so
no worries.
Thank you.
Happy to do it.
And we'll catch everybody next time. Thank you.
Okay. All right.